Esteemed jury, dear participants, listeners, ladies and gentlemen, on behalf of the Students' Scientific Society of Medical University of Silesia in Katowice, I would like to thank you for coming and taking part in International Medical Congress of Silesia 2024. My name is Miłosz Kasprzyk and I have an honor to coordinate internal medicine session. I would like to cordially welcome the esteemed jury, President of the jury, Professor Marek Hartleb, and members of the jury, Professor Jerzy Jaroszewicz, Professor Barbara Rogala, Associate Professor Szymon Skoczyński, Associate Professor Sylwia Dzięgielewska-Gęsiak, Dr Damian Gojowy. We would like to explain to you rules of the session. Due to some logistic problems, the order of the presentations had to be slightly changed. Participants received the order of the presentation yesterday. We will mention the number of the paper that is stated in the assessment card before and after the presentation. The maximal time of the presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time, one needs to move on to the conclusions and finish the presentation as soon as possible. Esteemed jury, I would like to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work. In that case, please cross out the number on your card. Other members of the same clinic are able to assess the presentation. The assessment should be on a scale from 1 to 5. We kindly ask you to assess scientific value, way of presenting, discussion, and own contribution. When the session ends, we kindly ask you to give the cards back to the coordinator. To begin, I think we can start with the first presentation. I would like to ask to present the paper entitled Allogenic Red Blood Cell Utilization Improvement Program in Non-Bleeding Hospital Patients, a pre-post study which is marked as number 3 on the assessment card. If the presenting author is ready, feel free to start the presentation.
Good morning, ladies and gentlemen, noble jury. My name is Julia Lipina, and today I've been honored with possibility to present you effect of my work with Dr. Piotr Szczępik, MD, PhD, on allogenic red blood cell transfusion utilization improvement program in non-bleeding hospital patients. Before I tell you about our study, I would like to start a little bit of numbers. It is estimated that 40 to 47% of patients being hospitalized suffer from anemia. And 1.7 and 1 to 1.0 million transfusions are performed each year, which is incredibly high number in comparison to only 1.4 million blood donations being performed each year. This only highlights the problem on worldwide blood deficit alerted by World Health Organization. Another side of the problem of transfusions is that, as any medical procedure, it is not free of risks and potential complications. They are listed in here, and some of them are deadly to our patients, and that's why it's so important to transfuse appropriately, to be very prudent while weighing risks and benefits of every transfusion. And now, as I acquainted you with these problems, I would like to move on to our study. According to them, and noticing them was thing that made us introduce new standard operating procedure of RBC transfusions in adult hospital patients. The premises of the new standard operating procedure were as follows. If hemoglobin was below 60 grams per liter, irrespective of signs or symptoms, patient needs to be transfused. Then, if hemoglobin goes below 70 grams per liter, and there are signs or symptoms of anemia present, we need to transfuse the patient. And then if the hemoglobin goes below 80 grams per liter in patients with coronary artery disease with signs and symptoms of anemia, acute coronary syndrome, acute cerebral ischemia, or myelodysplastic syndrome, we need to transfuse this kind of patients. As we know the procedure now, how the study was conducted. We've conducted it in a large academic center, being hospital here in Ligota. And we minded that the SOP was introduced at the end of the year 2022. We analyzed period from January to December, comparing 12-month periods between 2022 and 2023. And we retrieved the data from electronic health records and blood bank turnover. We've excluded RBC transfusions that were indicated by bleeding or preparation for surgery, so we're focusing on anemia, and now I will move on to the results. In year 2022, there were 2,081 transfusions performed overall, and out of them, 69% being 1,440 were transfusions by anemia indication. In 2023, this number already after the introduction decreased to 1,406 overall and 973 indicated by anemia. And now focusing just on anemia after a little bit of general numbers. The highest transfusing department was autoimmune and metabolic diseases and internal medicine department in our hospital. And in year 2022, they performed 293 transfusions. Second place was took by gastroenterology and hepatology department with 272. And the third of the big three, as we can say, was gynecology, obstetrics, and gynecology oncology department with 202. And as we can see by the graph, the numbers decreased because the lighter one are years 2023. And the most transfusing department noticed 157 decrease in number of transfusions, being 54%. Gastroenterology and hepatology was 94 transfusions decrease, being 35%. And the gynecology was 32 with 50% decrease. Other worth noting changes is 70% decrease in neurosurgery department, and that some of our departments decreased the number of transfusions by 100, going straight down to 0. Another thing is number of transfusions per person day in each department, telling us the real scale how the transfusions are performed. And once again, the lead is taken by autoimmune and metabolic diseases with 41.8 per 1,000 person days, decreasing to 24, which is really significant. Then second, when it comes to numbers per 1,000 person days, was ICU in our hospital, and they decreased from 38.8 down to 26.5 transfusions. And the first place took this time by internal medicine and clinical pharmacology, decreased by number of 9.1. When it comes to the effect on hemoglobin levels, the average level in 2022 before transfusion was 72 with median of 72. As we can see, it was quite equal in each department of the hospital. And the post-transfusion hemoglobin concentration was 90, and as well with median of 90, as in the same time being very leveled among the whole hospital. In 2023, these numbers dropped to 69 mean and median pre-transfusion in year 2023, and 86.5 mean and median, both again, in year 2023.
Can you please move to the conclusions because the time has run out?
Thank you. So, looking at those results, we can conclude that the new standard operating procedure helped us improving all the major metrics we use while judging the levels of transfusions in each hospital, and that it also improved appropriateness of transfusion, giving it only to the most needing patient, which is really important thing in the light of worldwide blood deficit we're facing. Thank you very much for your attention, and now I'll be pleased to answer any questions.
Thank you very much. I think now we can move to the discussion. Are there any questions from the jury?
So, okay, if you declare that the decision point for transfusion is only hemoglobin level, it is predictable that utilization of the blood will be reduced as well. But what is your opinion on decision on making transfusion? It is only the level of hemoglobin level or also the tolerance to anemia? Because tolerance to anemia may be different among patients.
Yes, thank you very much for your question. We're always taught that we treat the patient, not the test results. So the test results might give us this little nudge to consider transfusion, but we need to always look at our patient because, as you said, the tolerance to anemia is really diversified among the population. So we need to consider how the patient declares his feeling, not only how he feels, not only the results. We also need to consider if patient with that severe anemia or that not severe anemia, because if patient is clinically, he feels like he's anemized, he is dizzy, he feels shortness of breath, we will consider the transfusion, but we also need to think about the adverse effects as said about, like, for example, if the patient is not that anemized in results, we need to think, for example, of iron overload that is also really dangerous to our patient. So we need to judge multiple factors. We can't base only on numbers, but these numbers can be like a guidelines to us when we need to turn to the transfusion.
Thank you for a very nice presentation. I have like two questions. First of all, you have shown a cutoff point for a new system, but you haven't shown the previous standard in the hospital. Would you please comment on that? What has changed before introducing the system? Because it caused severe changes in the transfusion rate. And secondly, you've shown also that the highest decrease in transfusion rate was in the internal medicine autoimmunological department. In those departments, there are many fragile patients. Have you assessed the hospital length of stay being caused by the transfusion or not transfusion before?
Okay, so answering your first questions, before that, the hemoglobin level below 70 was considered as trigger for transfusion, and the rest was left to the doctor. Like, they didn't have guidelines for different states of the patient, so they focused mainly on the hemoglobin level, and then they were like, okay, this patient is in worse condition, so we will introduce it. And can you please repeat the second question?
The transfusion rate decreased significantly. Has it got an impact on the hospital length of stay of the patient's anemia?
The transfusions per se are, as you said, performed in the patient in the most critical conditions. So while analyzing the database, I haven't seen the critical differences, but we've only analyzed anemized patients. Some of them were returning patients. So for example, they were transfused, let's say 20 units in year 2022, and then according to the new procedure, in year 2023, when they came to receive the transfusion, they received only like 12 units, for example. So we haven't assessed length of stay per se, but we could see that some of the patients who returned, for example, for 3 times in 2022, in year 2023 appeared only 2 times, but we need to consider the possibility of patient's death in that or the switch of hospital. So these are data that are really hard to analyze in this light.
Thank you for your answer, but please consider it before the publication in the future. Thank you.
So actually my comment would be very similar to Professor Skoczyński. It's very good data, very interesting study, and congratulations. But before publishing, you would need also to analyze the outcomes. So the effect was there. It was very good effect, reduced numbers of transfusions, but the outcomes. So the outcomes is mortality, it's exacerbations, length of hospital stay. This is very important to have in publication. So nevertheless, congratulations on the study.
Thank you very much. I will remember that. But as you saw, I already ran out of time. So if I include the mortality, I think I will get kicked out of the stage. Thank you very much.
Thank you very much.
Oh, so as I'm not a licensed doctor, I couldn't be transfusing those patients or ordering transfusions, but all the data was collected by myself in March of 2024. Yeah.
Thank you very much. And now another paper with the same author, Mrs. Lipina, entitled Impact of a New Allogenic Red Blood Cell Utilization Program on Hospital-Wide Ordering Pattern, and it is listed as number 4 on the assessment card. Please welcome on the stage.
Good morning once again. I will allow myself to hold the stand a little bit longer. And this time I will tell you how the new policy I already introduced you to affected the hospital-wide ordering pattern in patients. So anemia is one of the most common diseases worldwide, affecting up to 1.95 billion people each year. It takes its toll by causing 52.1 million years lived with disability each year. And it is esteemed that up to 75 patients will acquire and suffer from anemia at one point during their hospital stay. In case of severe anemia, we always need to consider the transfusion, as I already said, but as also was said before, it is linked to higher mortality, longer stay, and more adverse outcomes. So as we were balancing the risk-benefit rate of RBC transfusions, we got the rationale for already introduced new standard operating procedure. But every new procedure introduced with hospitals is met with some problems. In this case being user compliance, because as we all know, old habits die hard, and the compliance with time, because as the procedure is introduced, everyone might comply to it nicely, but would they stick to it as the time flies by? So the aim of the study was assessing exactly these factors in the light of new standard operating procedure. And we did it by collecting the data, once again, in the UCK Katowice. And the period was once again January 2022 to December 2023. We checked the RBC transfusions with indication of anemia, and we reviewed the electronic medical records in the light of dividing the time period in 3 smaller periods, being pre-implementation phase, during implementation, and post-implementation phase. So now, as of the results, in the pre-implementation phase, the transfusion numbers for each month were 156 in January, 126 in February, 161 in March, being the highest number, 111 in April, 113 in May, and 99 in June. Overall, giving us 766 transfusions hospital-wide. As of the hemoglobin concentration, The average level, the level ranged from 71 to 77 pre-transfusions, with mean and median of 73. And the post-transfusion level ranged from 91 to 94, with the mean and median of 92. During the implementation phase that came next and embraced from July to December 2022, when it came to the transfusion number, there were total of transfusions being 674, with the highest number, with the peak in September being 135. And in this phase, hemoglobin ranged from 65 to 73 before transfusion, with mean and median of 69 and 70.5. And the post-transfusion range of concentration was 79 to 92, with mean of 87 and median of 87.5. And now the post-implementation phase that we judged for the longest period, being 12 months of 2023. There were 973 transfusions total. So as we can see, the drop was significant comparing to each period, pre-implementation combined together, with an unusual peak, and except for the unusual peak in the 6 months being June, for 159 transfusions, they ranged from the 79 to 92, from 62 and 91 transfusions per month. And when it came to pre-transfusion and post-transfusion hemoglobin concentration, this ranged from 67 to 71 pre-transfusions, so even the brackets smaller as the policy was introduced and complied to. And the post-transfusion concentration ranged from 79 to 91, with mean and median of 85.5. So to compare the results of all 3 periods altogether, we see that we've noticed, except for the June of 2023 I already mentioned, we noticed significant drop of transfusion number per month, and it stayed on pretty much the same level for the whole year, suggesting well compliance with the new policy. And as of hemoglobin concentration, we've also noticed drop of the pre-transfusion concentration, indicating that the doctors applied the new policy in their practice, and also a slight drop in the post-transfusion concentration, with the difference pre-post of 18 grams per liter for 2022 and 70.1 grams per liter for 2023. Moving on to the conclusions, we can see that the gradual implementation of the new policy put the effect already during the implementation phase as it was introduced. The effects of the new policy persisted through the year and continued into our follow-up. And the biggest conclusions we can get from that is that the new policy changed the ways of our doctors, with the benefit to our patients and to the hospital system. Thank you very much, and now I'll be pleased to answer any questions once again.
Thank you very much for your presentation. Are there any questions?
Of course we have questions. Congratulations again. Being myself a physician, I know that physicians are not very keen to follow new guidelines. What was the implementation of the guidelines, how effective it was? Whether you measure it, whether all transfusions were done according to new hospital guideline?
We did not judge all the transfusions, all the single transfusions. We looked at the overall trend and of change, suggesting that the new policy was introduced. And as you said, as the doctors were not really keen of new guidelines, the new changes, We implemented it by first educating our doctors on transfusions barely, as the knowledge on transfusions can be very poor among some groups. And then we also changed our system so it will be easy to comply, because when doctor orders the transfusion in the system, he has to pick the indication. So we included the new guidelines as the new version for anemia. So we said, like, what's the indication? Anemia below 80 in this and this and this type of patient, anemia below 70 in these types of patient, and anemia below 60 in all patients. And that also helped us to see which indications were chosen by the doctors as we took the results from the system and analyzed these trends.
Okay, very nice. However, you need to assess it before publication, because you will be asked by the reviewer for sure.
Okay, thank you very much.
Thank you.
You excluded acute bleeding.
Yes.
But generally there are two etiologies of chronic anemia. One is chronic loss of the blood through digestive tract, for example, and the second etiology of anemia is chronic inflammation. So my question is, in this new novel SOP, is there any discrimination between two etiologies, and if a decision depends on etiology of anemia?
Actually, thank you for your question. The thing is that the new SOP applied to the patients with anemia and results, and as I said before, the symptoms, and we excluded the bleeding or chronic bleeding from it because we can...
Yes, but if etiology matters, in this SOP?
The etiology of anemia?
Yeah.
Yes, however, we have separate indication for transfusion in our hospital being bleeding exactly. So we consider that the patients, for example, with chronic bleeding in their intestine or any other kind of chronic bleeding or chronic blood loss are considered as a bleeding patient, not anemic patient. We differentiated it because when patient bleeds chronically, we have to even more apply the rule, treat patient, not the results, and help our patient to regain the blood he lost, no matter if his hemoglobin levels will be 140 grams per liter or 60 grams per liter or 22 grams per liter.
Thank you. Thank you.
Thank you.
Continuing the thought of Professor Mark Hartleb, I would like to emphasize, what do you think about it? That it is absolutely necessary to take into account when we think about the risk of adverse event, of the potential risk of adverse event of a transfusion, the cause of anemia. Because the immunopathophysiciology of the diseases, chronic inflammation, neoplastic diseases, is important in that. Not only the number, as we can see, as we can say.
Yes.
Yes? Agree?
Yes, completely agreed. However, I would like to emphasize that we focused on the parameters that are, I would say, touchable to us, that we can see. And to be honest, while doing my research for the paper, I searched for how often certain adverse effects appear between the patient groups. And I was shocked to find that there's not that many studies on it with a huge value telling us that, for example, patients who are bleeding are more prone to those complications. Patients who are anemized, because as sometimes we hear that's their nature, are more prone to those. So that might be another thing that we would need to add to our database to make our study more full.
Well, thank you. So you notice this problem in your publication. Yes. It is important. You agree with me?
Yeah.
Thank you.
Exactly. Thank you very much.
Thank you very much. Now I'd like to invite the author of the paper entitled The Impact of the COVID-19 Pandemic on the Quality Indicators of Lower Gastrointestinal Endoscopy. And I would like to remind that this is the number 1 of the assessment list.
Good morning, ladies and gentlemen. My name is Jakub Prosowski, and today I'd like to talk to you about the impact of COVID-19 pandemic on the quality indicators of lower gastrointestinal endoscopy. Colonoscopy is an examination that allows us to detect and prevent colorectal cancer by removing lesions at an early stage. During the COVID pandemic, many safety measures were taken and personal protective equipment was used that could have an overall effect on the quality indicators of colonoscopy. Also, patients' fear of virus transmission also could delay the overall diagnostics. And this is basically the purpose of the study, to see how the SARS-CoV pandemic affected the quality of colonoscopies. The study was made in a single center. It's a retrospective analysis made from January 2019 to December 2021. The onset of the pandemic we treated as 11th of March 2020. There were 10 operators that performed colonoscopy during this time on symptomatic patients, patients presenting with bleeding, anemia, weight loss, and so on. And those were the evaluated parameters. Those are the quality indicators that I was talking about. It's cecal intubation rate, as well as the detection rate of polyps, adenomas, advanced adenomas, and malignant tumors, and their number per colonoscopy. There were 3 points in exclusion criteria. It was incomplete data on the patient, mostly due to incomplete examination. It was in a case where lesion was detected but not removed, or when it was removed but it wasn't examined under histopathology. And there were also patients that were not prepared adequately for colonoscopy. For that, we used the Boston scale, in which we measured all 3 segments of the colon, and if any of the patients received less than 2 points in any of the segments, then we regarded them as unprepared. After the exclusion, we were left with 3,371 patients. When it comes to the data on the studied groups, as you can see, more patients were female. Most of them were sedated during the procedure. A significant number of inpatient population dropped during COVID. The mean age was 55.82, and most of the patients were adequately prepared. When it comes to the parameters that we wanted to measure, as you can see, CIR, so cecal intubation rate, adenomas detection rate, and adenomas per colonoscopy, those parameters did not differ significantly before the onset of COVID and after the onset of COVID. What did change, however, was PDR, so polyps detection rate, PPC, so polyps per colonoscopy. Those parameters increased during COVID, as well as malignant tumors. This parameter also increased. What decreased, however, were the 2 first parameters, AADR, so advanced adenomas detection rate, and advanced adenomas per colonoscopy. And here we have 2 charts. I'll try to break this down for you. We have 10 operators each on 2 of the charts, and in the blue boxes I marked the operators that had their detection rate increased, and in red boxes the detection rate that decreased. And as you can see, when it comes to advanced adenomas, the majority of the operators had their detection rate decreased. And these are the main conclusion that I would want you to take home with you, is the fact that because of the pandemic, we had a decreased detection rate of advanced adenomas and their numbers per colonoscopy, and an increased detection of malignant tumors, and overall number of polyps and polyps per colonoscopy. Thank you very much.
Thank you very much for your presentation. Now we can move to the discussion. Are there any questions from the jury?
Each study should have hypothesis. What did you expect studying this subject, and what is your interpretation of this data? What is your
Well, first of all, we have to notice the fact that the advanced adenomas detection rate decreased. This is our hypothesis is that due to the fear of virus transmission, patients didn't want to have any examination, and they only went to the doctor when they had severe symptoms. Because of this, most of the advanced adenomas turned into malignant tumors. That's why we have an increased detection of malignant tumors. And that's probably why we had a decreased number of advanced adenomas.
Yeah, so the conclusion, in fact, is gloomy, because you found less advanced adenomas and more malignant.
Yes.
So it confirms the expectation that the diagnosis was delayed in these patients, yes, because of the pandemic.
Yes, there was after the onset of COVID, there was about a 2-month hiatus where there were very few colonoscopies. This probably affected the study most.
Okay.
So again, congratulations. Did you have any chance to look at the data post-COVID? Because in order to see your conclusion, you would need to prove the trends. It's only 2 years apart, yeah? So what happened in 2022, 23? Are those ratios normalized, or are you still analyzing the data? It would be important to see this.
We're still analyzing that, but what we found also is that even during COVID, those numbers of colonoscopies, they actually even increased because, well, the operators and the whole healthcare system adapted to the situation. So if you were to look at the data, except for this about 2-month period, we actually performed much more colonoscopies.
I agree with Professor that you need to do the follow-up as well, because the change from a polyp to the tumor takes, in general, several years. So comparing year to year might not be that sensitive. But you haven't mentioned anything about the particular impact of each person or yourself in the study. As we asked the previous presenter, here you have a larger group. Would you please tell what was your role in the...
My contribution, I collected the data from colonoscopy and histopathology results on about 1/3 of the patients.
Thank you.
Thank you.
Thank you very much. Now I would like to ask to present the paper entitled Vitamin D Deficiency in Liver Cirrhosis, a Forgotten Piece of Puzzle, and it is number 2 on assessment card.
Good morning, dear committee members, dear students. My name is Karolina Osińska, and together with Agnieszka Morawa, under the supervision of our tutor, Docent Joanna Musialik, we would like to present you our work, Vitamin D Deficiency in Cirrhosis, the Forgotten Piece of the Puzzle. Now let's start with some physiology. Biosynthesis and metabolism of vitamin D is well known to all of you. But nevertheless, I would like to remind you that one of the stages occurs in the liver, It is well known that vitamin D plays a great role in many metabolic functions, but I would like to focus on its liver support. And before I move on, I would like to underline its relationship between HEPA and vitamin D level. Hepatic failure contributes to low serum 25-hydroxy vitamin D levels. And at the same time, vitamin D is necessary for liver recovery. And for example, vitamin D limits steatosis and fibrosis in both alcohol and non-alcoholic liver disease. It works anti-inflammatory in autoimmune hepatitis and viral hepatitis. What is more, it improves responsiveness to antiviral treatment. And the best indicator of vitamin D concentration is calcidyl concentration, 25-hydroxy vitamin D. We can obtain it by radioimmunological and radioimmunocompetent methods and high-pressure gas chromatography. And then, vitamin D status can be divided into deficiency with calcidyl concentration below 20 nanograms per milliliters, then suboptimal concentration, 20 to 30, and high concentration, it means proper concentration, above 30 nanograms per milliliter. In our research, we compared the degree of hydroxycalciferol deficiency in cirrhotic patients. They were our research group. And in patients after liver transplantation, they were our control group. We evaluated calcium phosphate metabolism in patients with cirrhosis, regardless of the etiology. And we analyzed the relationship between vitamin D concentration and liver function tests. Our research group consisted of 62 patients with cirrhosis, and our control group consisted of 29 patients after liver transplantation. When it comes to the etiology of liver cirrhosis, the most common was alcoholic liver disease. The rest were post-inflammatory, autoimmune, and other causes. In our research, we assessed calcium and phosphate metabolism parameters, coagulology, and blood biochemistry parameters. Here you can see clinical characteristics of the patients. There are statistically significant differences between our groups to our control group advantage. Now let's move to results. In our research group, nearly 68% of patients suffered from vitamin D deficiency. In only 3 patients, the level was proper. And in contrast, in our control group, the proper level occurred in nearly 38% of patients. 31% of them suffered from deficiency. Now I would like to compare both groups. As you can see, 2 times more patients in our research group suffered from deficiency comparing to our control group. In patients with proper vitamin D level, the difference was even bigger. You can see it at first glance, but of course, everything was statistically confirmed. As I said, 68% of patients with cirrhosis had decreased concentration of vitamin D. And in our research, we observed that the most predisposed were post-inflammatory patients, it refers to 100% of them, and patients with alcohol liver disease, it referred to 94% of them. Now, I would like to draw your attention to MELD index. MELD is a scoring system for assessing the severity of chronic liver disease. In brief, the higher MELD, the higher observed mortality. In our research group, the average MELD index value was 11. And in contrast, In our control group, the value was significantly lower. We also assessed non-parametric Spearman correlation between vitamin D and albumin, bilirubin, INR, and MELD. In brief, when vitamin D decreased, also albumin decreased, and at the same time, bilirubin, INR, and MELD increased. In our research, we didn't observe any calcium and phosphate metabolism. We didn't observe any correlation between calcium and phosphate metabolism parameters and liver function tests. We also compared our results with observation of other researchers. They are consistent. It means that vitamin D concentration decrease in cirrhotic patients regardless of cirrhotic etiology. Now let me summarize our research. Our patients have been treated for a long time by general practitioner or specialist. Also, the relationship between the liver and vitamin D correlation is well known. The concentration of this vitamin has not been routinely measured. In our research, we observe a strong correlation between vitamin D levels and liver function parameters such as albumin, bilirubin, and MEL index. It means that decreased level of vitamin D correlates with the increased cirrhotic patient's mortality. And the last, monitoring of serum vitamin D levels must be taken into account when treating patients with cirrhosis. That brings us to the end of our presentation. If you have any questions, feel free to ask.
Thank you very much for your presentation, and now we will move to the discussion.
Thank you very much for your presentation. Very nice one. So everyone understands the importance of vitamin D in liver cirrhosis, but there are two important issues to be raised here in this study. First, were those patients supplemented by vitamin D? Because some of the patients post-transplant might be supplemented because of the protocol of the department.
No, they weren't supplemented.
Very good. And second, you of course know that you need to compare the patients from the same season.
Yes.
So summer, winter.
Yes,
it was
yes,
also done.
Yes, yes.
Very good. Thank you.
I have one question, because you presented that those patients with low vitamin D levels had in fact normal PTH, normal ionized calcium. I don't remember if there was phosphate level.
Yes, there were.
And it was also normal. Yeah. So my question is, do you see indication to give to those patients vitamin D, and what could be the effect of supplementation of that vitamin in those patients? What do you expect?
Yes, I see indication, because as I said, vitamin D limits steatosis and fibrosis of the liver.
Okay, thanks.
Please remember about the contribution. You need to always mention the contribution we are asked to market as well. The contribution to the study, because this is one of the 4 points we need to score. So please always follow that. I need to tell in this point that it happened once to me that the students from my group came and said, "Doctor, we want to perform our study according to our idea." So if something like that happens, please tell it as well.
Okay. Thank you.
Can you tell us your contribution to the study?
Our contribution, yes, we completed our data since January to April, and we are still working on our research.
Thank you very much. Now I'd like to ask to present the paper named IgE-dependent Alzheimer's disease. number 5 of the assessment card, and now the order will be exactly like on the assessment card.
Good morning, ladies and gentlemen. Thank you so much for having me today. My name is Alexandra Spyra, and I'm really honored to present you the results of our retrospective multi-center cohort study about high prevalence of Alzheimer's disease in patients with Ig-mediated allergy. Sorry, I have a problem with... Alzheimer's disease is a common neurodegenerative disorder with extracellular amyloid deposits, mainly beta amyloid. There are many hypotheses regarding the pathogenesis of Alzheimer's disease, but not all of them have been proven in research. Neuroinflammation is believed to play a crucial role in the neurodegeneration caused by Alzheimer's disease. The presence of inflammation in the brains of people with mild cognitive impairment and Alzheimer's disease has been confirmed in research. Various mechanisms of this inflammation are considered, including the induction by peripheral inflammation and high levels of pro-inflammatory cytokines. On the other hand, some bacterial or viral infections may also accelerate this neurodegenerative process. The effect of allergic inflammation on Alzheimer's disease is an interesting phenomenon. Due to the wide scale of allergic diseases, the possible relationship with dementia diseases should be analyzed. Several studies have evaluated the impact of individual allergic diseases on cognitive processes. Some of those studies involved using animal models. Allergies in mice may affect their behavioral disorders, including cognitive processes. The interleukins 4, 5, and 13 and high IgE titers may be responsible for this. It has been observed that the presence of allergic bronchial asthma may harm cognitive processes in humans, especially in patients with uncontrolled and/or severe disease. Systemic inflammation accompanying Ig-mediated allergy may influence the induction of neuroinflammation and consequently dementia. This study was designed to assess the risk of developing Alzheimer's disease in patients with clinical symptoms of Ig-mediated allergy. It was a retrospective multi-center cohort observation. The data were collected from 12 selected centers, which served as allergy and geriatric clinics where patients were treated. The inclusion criteria were age over 50 years and confirmation of inhalant Ig allergy. In total, 7,129 patients were examined. Data regarding allergic asthma, allergic rhinitis, and atopic dermatitis were collected. These diagnoses were based on the ICD-10 code, at least 6 months of documented treatment, and the results of allergy tests. These patients formed a study group. The remaining patients without signs of allergy were included in control group. All subjects were analyzed for the presence or suspicion of Alzheimer's disease, and the criteria for confirming this disease were at least 6 months of documented treatment and confirmation of the diagnosis in the ICD-10 code, CT imaging of the brain, and the results of questionnaire tests. Means, medians, and standard deviations were calculated in the analysis. The Shapiro-Wilk test and ANOVA were used to test normal distribution. The Kruskal-Wallis test for non-normally distributed variables. Spearman ran correlation test to analyze correlation and hazard ratio for some variables. Bonferroni correction was applied in the statistical analysis, and the p-value less than 0.05 was considered to indicate statistical significance. Finally, 1,215 patients with diagnosed allergy were included in further analysis. The remaining 5,914 participants constituted the control group. These slides show characteristics of participants. We collect data on the age, gender, marital status, educational level, nicotine addiction, body mass index, place of residency, allergic diseases, family history of allergy, and following comorbidities, for example, coronary diseases or depression. The results were as follows: a significantly higher frequency of diagnosed and treated Alzheimer's disease was confirmed in the group diagnosed with allergy compared to the control group. Patients with Alzheimer's disease had a higher mean serum total Ig concentration. The percentage of eosinophilia was significantly higher in the group diagnosed with Alzheimer's disease. The presence of sensitization to the tested inhalant allergens had no significant effect on the diagnosis of Alzheimer's disease, except for a positive correlation with allergy to Dermaphagoides stenosinus. Allergic asthma was significantly more common in the group diagnosed with Alzheimer's disease. The presence of 2 or more allergic diseases at the same time increased the risk of Alzheimer's disease. Allergic rhinitis and atopic dermatitis occurred in similar numbers in both groups. Based on the results, the following conclusions were made. IgE-dependent allergic diseases, in particular allergic asthma, and the presence of high serum IgE levels may favor the development of Alzheimer's disease. More detailed research is needed to investigate the mechanism behind this phenomenon. Thank you so much for your attention.
Thank you very much. Can you tell us what was your contribution to this work?
My participation was data collecting, analyzing, verifying, and preparing for statistical analysis, and of course, analyzing literature.
Okay, thank you. Now we can move to the discussion.
Congratulations on your presentation. This is a really innovative observation. Why I would like, I allow myself to say it. Because taking into account the main immunopathophysiciology of these disorders, allergic inflammation, IgE-dependent sensitization, but not always allergies. Allergy is the diseases. IgE-dependent sensitization is the immunological disorders. Is Th2 dependent. And Alzheimer's disease is Th1 dependent. So it is provocated to discussion, this observation. Completely different, no, not completely, but different immunopathophysiciology. On the other hand, there are some data, not rather well known, that even the IgE-dependent sensitization, it means atopic person, reduce risk of cardiovascular diseases, atherosclerosis diseases. That is such important data and common knowledge in the field of immunology. So your observations are really innovative and provoking to discussion. You always, in each and every patient, IgE sensitization to airborne allergen was estimated. Not only the clinical estimation, the diagnosis of allergy, because allergy is the disease and not always caused by IgE-dependent sensitization. For example, asthma, bronchial asthma, the vast majority of cases, atopic dermatitis, chronic urticaria, and so on. So thank you. But
thank you very much.
Stimulating to discussion and to further research, so it is worth noticing. Thank you.
Thank you.
I admire your work, and you already said that you did statistics. And as we saw, the statistic is very nice, but Alzheimer's disease is a multifactorial problem. And we saw that not only IgE allergy differ between groups, but also obesity, for example, as you show in your presentation, and blood pressure. Did you perform multifactorial regression analysis, and did you find any differences, or you exclude some problems?
It's just a part of a large study. We here focused on epidemiology, and in further analyzing we will be discussing these factors in pathomechanism of Alzheimer's disease.
Thank you, congratulations. One more question about the anti-allergy, anti-asthmatic, and immunotreatment of those patients. The group was pretty large, so I guess there must have been like significant differences in the anti-allergical treatment. Have you analyzed that? Could you please comment?
Can you repeat the question? Sorry.
There was a high number of allergic patients. Some of with asthma, some with dermatitis, and there are different drugs groups which you may use to treat the allergic diseases. Have you analyzed the treatment of the allergic people and its impact on the Alzheimer's disease?
The treatment were for disease, allergic disease. So if patients had asthma, the treatment were based on the treating of asthma. We didn't analyze the income of treatment, separate diseases on Alzheimer's disease.
As because the treatment of asthma may be very difficult, so it might happen that some of the patients are treated in a suboptimal way. The asthma might be controlled or not controlled, and it may also have an impact on that. So I guess it's important to assess that as well.
Yes, yes.
Like topic glucocorticosteroids or the synthesization, some of them probably have been synthesized when they were younger. So this should be also included in the analysis. Thank you.
Thank you very much.
Thank you very much. Now I would like to ask to present the paper entitled Dupilumab, a new biologic therapy efficacy for severe asthma.
Good morning. So today I would like to present Dupilumab, especially for Associate Professor Skoczyński. I think this will be an interesting topic. So let's move on to asthma. Asthma overall is a heterogeneous disease. It affects over 350 million people worldwide, and according to data from the National Health Fund, it is approximately 4.9 million of people in Poland. So it is a very serious issue. What is important to mark here is the fact that asthma can be treated if we follow the proper recommendations. And this is why we are looking at Dupilumab, which has only been registered from 2023. According to Joanna, the therapy goals here are decreased exacerbations, decreased symptom prevalence, no sleep disturbance, and no limitations in physical activity. What is important here is that severe asthma is defined by the European Respiratory Society as the one that requires more treatment. So we have a second controller needed, and despite the fact that we have a second controller, the patient is still not healthy. So the available biological treatments in Poland currently, we have 4. Those are omalizumab, this one was the oldest one, mepolizumab, benralizumab, and dupilumab, which we'll be focusing on today. So dupilumab, I won't talk about all of the 3 because obviously we won't have the time, but dupilumab is the only one that affects dual pathways. So it blocks both interleukin-4 and interleukin-13. What is important is that we will have a new biological therapy, tezepelumab, which will actually work further, so it will actually block TSLP, and therefore the interleukins won't be released. And overall, we can see here the clinical efficacy rate. It is pretty high. It is pretty rare that the patients don't respond properly to treatment, but obviously it is important that some patients might not have the proper mechanism of asthma, and there's really no way to determine if the patient has allergic asthma or eosinophilic asthma once we actually treat biologically. And therefore, we have some patients that have multiple biological therapy. The aim of the study was the analysis of the efficacy of dupilumab. Since it was only registered last year, we only have 22 patients, so it is only the first control point after 6 months. So as mentioned, 22 patients, we had 7 male and 15 female. So this really corresponds to the trend that asthma is mostly diagnosed in females after the age of 40. Interestingly enough, in terms of pediatric asthma, boys are the ones that have asthma more often, and according to pediatricians, they are laughing that it's because the mothers are more sensitive to their boys than to their daughters. So the data range was from 2023, and we have evaluated asthma quality of life, asthma control, GETA, which is the scale, really a qualitative scale, where we measure if the patient is okay or not. And this is really just by seeing the patient, the decrease in exacerbations, and the decrease in the systemic glucocorticoids. So really, as mentioned, 22 patients, not a very big group, and the age mean was 54, the range was 30 to 79. And as you can see here, mostly we had patients from 30 to 49 years old, and then there was a peak at 70 and 79. Because dupilumab is one of the drugs that is used for multiple diseases, such as nasal polyps, allergies, and atopic dermatitis, we had to evaluate if the patients should require the higher dose or the lower dose. So the higher dose obviously is with patients that have nasal polyps and allergies, and as well as atopic dermatitis, which is not shown here, but only 2 of our patients have atopic dermatitis, and they have both being qualified for the 300 milligram dose. What else is important here is that 4 patients had previous biological therapy. So in this case, this means that in pulmonology, we never delete the patient if he doesn't respond to biological therapy, but we are looking at something to help him and to have a better life. So here is a summary of the results. And as we can see here, we have all of the summary at the baseline. And really, this is all I've said on the next slide as well, so I think we will skip. And we'll go ahead. And of course, here we can see that the patients have obstruction in the FEV value. Oh, for the previous biological therapy, I might mention that 1 person had mepolizumab, and mepolizumab was stopped due to poor clinical response. 1 young patient is 40 years old, and she is now currently treated with dupilumab. Previously, she was treated with omalizumab and benralizumab, and she didn't respond correctly as well. She still had to take glucocorticoids. And 1 patient was mepolizumab as well, and this patient, again, had no proper reduction in steroids. So here we have the mean asthma control questionnaire and asthma quality of life questionnaire values at control point 1. What is important here is that for AQOQ, we are looking for an increase of at least 0.5, while for ACQ, we're looking for a decrease of at least 0.5 points. And as we can see here on the table, all of the patients have actually responded well so far. So we are pretty happy with the results in terms of dupilumab. One patient is at the border, but the reason for the border is that the patient, because asthma quality of life questionnaire, the patient has to say on their own if they are feeling better. We think that it's mostly psychological, that the patient is saying that it's worse because the results for the first expiratory volume are better. So in this case, for us, we think that it is also working. So far, no patients have been excluded from the treatment. And here we can see a summary of the mean change. So as we can see, asthma quality of life has increased by at least 2.2 points, and asthma control also decreased by at least 1.48 points. And actually, before we go to the conclusions, what I'd like to mention is that we have made a comparison between the 200 milligram and the 300 milligram dose. So as we can see, the changes in the 300 milligram dose was higher, and we predict that it is because of the concomitant disorders, so the atopic dermatitis, the allergies, and the nasal polyps. Because we have treated with dupilumab, it might also improve the patient's overall state. And so, to conclude, we have a higher efficacy rate than in prior randomized clinical trials. The biological therapy is highly effective overall for the treatment of severe asthma, and the failure of treatment does not rule out another biological therapy trial. For example, we have one patient, he is not treated with dupilumab, but overall he has been treated with 3 different biological therapies, and only the last one actually worked, and now he's even parachuting. So biological therapy is definitely something great for patients, and dupilumab treatment yields positive effects irrespective of concomitant diseases, because the 200 milligram dose also showed a positive effect. What I wanted to add is that in biological therapy you never know what will work, so you have to sort of make sure that the patient is well, is giving the history properly. So we have to ask a lot of questions. And for the side effects, because I've been asked this question during a conference last year, really there are obviously side effects, but the patients never mention them because usually they are very happy with the results of biological therapy. Thank you for your attention.
Thank you very much. Can you tell us what was your contribution to this work?
So I think the departments will be able to tell you that I'm a favorite person, and they are always laughing that I should just be working there because I'm just there all the time. So actually, for my personal contribution, I was collecting the data. I was also helping Dr. Farnik with actually inputting the patients into SMPT, which is the National Health Fund program for biological therapy. I've also talked to the patients, and I was looking at the spirometries as well. And I also did the data analysis and the data collection. So overall, I think my personal contribution was pretty great in this work.
Okay, thank you very much. Now we can move to the discussion.
Congratulations on your enthusiasm, and also I'm very happy that you do a lot of things in the department, so we are really a precious one to them. So only one question. I like your data very much, but I didn't see, did you compare the quality of life dynamics with some control groups, some other biological therapies? This would help a lot for us.
So actually, because we've analyzed benralizumab, mepolizumab, and omalizumab previously, and they show a very similar results, except in omalizumab, because it is the older one. So some patients at the beginning, they didn't respond well, and many of them were actually switched to benralizumab or mepolizumab once they were introduced. But overall, the changes are pretty similar.
Also, I would like to congratulate the presentation but dealing with such patients, what do you think? We believe that the biological therapy is a spectacular progress in medicine. And taking into account the main mechanism of bronchial hyperactivity, eosinophilic inflammation, not only mediated by Th2 activity, but also ELC2 activity. What do you, according to your experience, what do you think the more efficient is IL-5, anti-IL-5 therapy than anti-IL-4 and 13? because I think that the more efficient therapy is anti-IL-5 because it blocks the activity of eosinophils, recruitment, and so on. So suppress the eosinophilic inflammation with all the clinical consequences. What's your opinion?
I think I would agree, especially seeing the data from the patients with mepolizumab and benralizumab, yes. Especially if we look at the patients that had omalizumab. But for those patients that have the four patients that had the previous biological therapy, 2 of them had mepolizumab. And at the first control point, they were also responding pretty well. So it is hard to say if dupilumab is more efficient for them than mepolizumab will be. So we will have to wait for further results.
Yeah, thank you. So we have the possibility to choose the proper biological monoclonal antibody to proper patients, so personalized therapy is
yes, exactly.
Is important.
So
Thank
actually for the patients that have dupilumab now, the ones that had previous biological therapy yes. just didn't respond yes. well, so now that is why they have dupilumab, and the others that have been qualified, they simply have the nasal polyps.
But in spite of this problem, asthma remains treatable but not curable.
Yes, unfortunately.
And all allergic diseases, yes?
Exactly.
Fine, thank you.
Okay, we are witnessing a real explosion of biologics. For example, inflammatory bowel disease, 3-4 preparations per year emerge. In all autoimmune diseases, it is one of example. And sometimes in medicine, you know, the success of one doctors in one field is the problem for doctors in another branch. So my question is, what do you know about side effects of dupilumab, unwanted effects?
Mm-hmm. So we think that the more dangerous one is hypereosinophilic syndrome. And actually, at the beginning of the work, me and Dr. Farnik, we created a questionnaire for the patients, which they fill out during the control point. And so far, no patients have actually shown hypereosinophilic syndrome.
There is no liver injury, kidney injury, there are
no patients
reports
have,
of that.
No.
Okay. But sometimes
probably
we know very little about new drugs, and this knowledge will develop if a drug will be marketed.
Okay, thank you very much. Okay, now we'll have the online presenter for the paper entitled Analysis of Factors Affecting the Efficacy of Syphilis Therapy in People with HIV. Please share your presentation on the Zoom.
Good morning. Is it visible?
Yes, it is.
Okay, so dear listeners, dear jury, my name is Alexandra Hejnoš. I'm a fifth year medical student and a member of Student Scientific Society at the Department of Infectious and Tropical Diseases and Hepatology at the Medical University of Warsaw. Our study resolves the factors influencing the course of syphilis in people with HIV. As far as we know, this is the first research in this field that includes Polish patients. First, it is worth mentioning that syphilis and HIV co-infection presents a serious global health problem as well as can be diagnostically challenging. HIV can alter syphilis symptoms either by aggravating them or by suppressing them. Moreover, people with HIV express a higher incidence of syphilis serological failure, defined as a lack of fourfold loss in VDRL titers after the completion of syphilis treatment. Our interest also comes from the fact that both HIV and syphilis are on the rise, despite the era of widely accessed antibiotics and the era of ART. And so, as you can see, in 2020 worldwide, there were 7.1 million new cases of syphilis. The graph presents the incidence of syphilis in Poland, as you can see, there was a 77% rise in year 2022 in comparison to year 2021, giving approximately 2,000 new infections. And with that, here we present the factors analyzed in the research. It involved 44 male patients, and the first day of syphilis therapy also marked the beginning of laboratory testing. All tests were performed and risked 3 times, starting from the first day of syphilis therapy. And then the post-treatment data was collected during the visit scheduled at 6 months for early syphilis and at 12 months for late syphilis. The data was then analyzed using specific methods with p-values set at 0.05. And with that, we can move on to the results. The first table represents the baseline of the analyzed group. As you can see, the high values of HIV-1 RNA viral load show the importance for testing for HIV in all people infected with other sexually transmitted diseases. One explanation for this fact could be that syphilis tends to increase this factor. What is interesting is that this value decreased steadily during the observation. It was also observed that CD4 T lymphocyte percentage increased in all patients after the syphilis treatment. Limited studies analyzed this specific factor, though some demonstrate that CD4 T lymphocyte count tends to be lower at the beginning of syphilis treatment and eventually increase after the completion of the treatment. Also, out of 44 patients included in the study, 6 of them presented with serological failure. What is interesting is that all of these patients had relatively high CD4 T lymphocyte cell count in comparison to the rest of the group, with above, on average, above 500 cells per millimeter. And neither of them were newly diagnosed with HIV, and all of them were successfully treated with ART. Also, as you can see, the majority of the patients with a lack of significant decrease in VDRL titers had late syphilis. The treatment regimens, including class of ART or type of syphilis treatment, did not seem to influence the course of the disease. Lastly, univariate analysis confirmed the positive correlation of CD4 T lymphocyte count and late syphilis, and the negative correlation of primary syphilis with serological failure. Last but not least, we can present the following conclusions. Early detection of syphilis in people with HIV improves treatment outcomes. Monitoring serological reactions is advised for all people with HIV, regardless of ART treatment or immunological status. Also, even people with undetectable HIV-1 viral load and CD4 T lymphocyte cell count above 500 cells per millimeter are at risk of serological failure. Thank you for dedicating your time to this presentation, and I'm happy to answer any questions.
Okay, thank you very much. Can you tell us what was your contribution?
Basically, I was the one who came up with the idea to perform this research. It was during my classes of infectious diseases when one of my professors mentions this observation that approximately 10% of patients with HIV and syphilis have serological failure to treatment, and this trend was confirmed in my study, and it also is confirmed in other studies on the subject worldwide. I was also the one who collected the data and the one who analyzed other studies on this subject, and yes, and the one who also came up with the conclusions.
Okay, thank you very much. Now we will move to the discussion.
So congratulations, it's a very important subject, very important study, and it's good that you studied it. And indeed, it might be first Polish analysis of the subject, but there is one crucial question to be asked, because you suggest that anti-syphilis therapy has a role in the increase of CD4 T cells during the therapy. But all of the patients received antiretroviral therapy. Without the control group, it's very difficult to say so. So why do you think that the therapy of syphilis increased CD4 more significantly than the antiretroviral therapy alone?
I may have there might have been a misunderstanding. What I meant was that syphilis itself, not the therapy, influences the viral load, and it is not something that it is something that other studies suggest.
Okay, so nevertheless, if you would have a control group of patients without the syphilis, very similar characteristics, and you would control them 6 or 12 months later and compare CD4 and viral load, it would be very interesting to see those data.
Yes, I have also been thinking about the control group, but the thing is, it was very difficult to even collect the data for this group, because the thing is, we had to exclude approximately 100 patients because they wouldn't appear to the they wouldn't count to the follow-up visit. So it is quite difficult to make two groups.
Yes, true indeed. So if I can ask one more question, how many of those patients were foreigners? What was the proportion of immigrants in this group, or all of the native?
As far as I remember, there were maybe one patient who was foreigner. Yes, and he was Ukrainian, but he would live in Poland. Yes.
Okay, thank you very much. I think we have no more questions.
Thank you for the questions. Thank you.
Okay, now I'd like to ask to present the paper entitled Cardiovascular Risk Factors in Patients 2 years after Successful Liver Transplantation.
So good morning, ladies and gentlemen. My name is Dominika Sarna, and today I would like to share with you the results of our retrospective study about cardiovascular risk factors in patients 2 years after successful liver transplantation. Liver transplantation stands out as the primary effective method for treating end-stage liver disease, and cardiovascular complications are frequently observed in these patients. This study aimed to assess cardiovascular risk factors among patients after liver transplant, and considering that the cardiovascular diseases emerges as a third most prevalent cause of mortality following liver-related factors and malignancy-related deaths, it is crucial to understand those risk factors, because they can offer targets for interventions that may affect long-term survival of those patients. This study involved 243 patients, 91 females, 152 males, with an average age at the time of a transplantation of 50 years, and they underwent liver transplantation between 2005 and 2020 at the Department of General, Vascular and Transplant Surgery of the Medical University of Silesia in Katowice, Poland, and who survived with a functioning graft for at least 24 months. All transplantations were performed using cadaveric organs, and subsequent to transplantation, patients received a follow-up care at the transplantation outpatient clinic. Among our patients, viral hepatitis was the leading cause of liver failure in 40.3% of patients, and it was followed by the alcoholic liver disease in 24.7% and autoimmune disease in 22.2% of patients. And regarding immunosuppression, 204 patients received tacrolimus, 22 patients received cyclosporin A, and 17 everolimus. A retrospective analysis of patients' medical histories and laboratory test results was conducted to assess the prevalence of following cardiovascular risk factors both before and 24 months after liver transplantation. And they were hypertension, type 2 diabetes, hypercholesterolemia, hypertriglyceridemia, smoking, and chronic kidney disease. And the statistical analysis was performed using McNemar test, chi-square test, and Fisher's exact test. And the results are presented as means with 95% confidence intervals. All mentioned cardiovascular risk factors were diagnosed using presented criteria. The prevalence of almost all analyzed risk factors increased, with the exception of smoking, where a decrease was observed. The prevalence of increased cardiovascular risk factors rose considerably. The hypertension escalated from 31 to 81%, diabetes from 19 to 43%, hypercholesterolemia from 11 to 46%, and hypertriglyceridemia from 14 to 35%, and chronic kidney disease from 18 to 30%. In this patient population, prevalence of all mentioned risk factors beside chronic kidney disease was statistically different between patients with different etiology of liver diseases. It is important to note that the alcoholic liver disease patients are characterized by the highest prevalence of all mentioned risk factors, while the lowest prevalence of those risk factors was observed in autoimmune diseases patients. We also observed differences in hypercholesterolemia and hypertriglyceridemia after 24 months, with a significant higher prevalence in patients treated with everolimus. Prevalence of hypercholesterolemia in those patients was 88%, while in patients using tacrolimus only 43%, and cyclosporin with only 41%. Similarly, 82% of patients treated with everolimus were hypertriglyceridemic, while only 31 of patients treated with tacrolimus and 32 patients treated with cyclosporin had this disorder. To conclude, cardiovascular risk factors are frequently present in patients long-term after liver transplant. And the etiology of liver failure and type of immunosuppressive therapy may impact cardiovascular risk factors prevalence in those patients. So appropriate diagnosis and treatment of those risk factors may reduce the burden of cardiovascular complication in patients long-term after liver transplant. So thank you very much for your attention.
Thank you very much. Can you tell us what was your contribution to this work?
Yes, me and the co-author Barbara Romanowska, we collected all the data of those patients. And we also did the statistical analysis and wrote this paper.
Okay, thank you. Now we can move to the discussion.
Very interesting topic. Congratulations. You have clearly showed that the number of cardiovascular risk factors increases significantly in a very short period of time. Was it enough to find any complications of that, like acute coronary syndromes or?
Yes, we are doing further research about cardiac arrest and neurological complications with those patients, but we are still doing it. So we hope that in the future we also will do the research about that.
Perfect. And one more thing, post-transplantic patients have an increased likelihood of cancer because of immunosuppressive treatment. And it clearly showed that the number of patients which are still smoking decreased significantly, but it should be 0. Could you please comment on that and whether there are any actions undertaken in the group? Are you in any contact with the patients, or you just do the analysis?
We ourselves, we are not the contact in any patients, but there was the patients were asked after transplantation if they quit smoking. Some of them did, some of them didn't, but they are encouraged to quit smoking.
I would like to make a comment. I think that interpretation is difficult, and comparison of the same patients before and after transplantation is risky because of confounders. Because metabolic characteristics of the patients is closely associated with liver failure. In cirrhosis, there is low cholesterol level due to liver failure. The arterial pressure is low due to arterial vasodilatation, and glucose also. The liver produces less glucose, so it all may change after liver transplantation. So this change, this sway is highly dependent of a new liver, of the functioning of new liver. Not so. The reasonable would be to compare, the person after transplantation and the same person 20 years before. It would be.
Yes, yeah. But we don't have the data to do that, unfortunately.
I know.
So maybe one last question about the alcohol, the same as Professor Skoczyński. So how many patients started drinking after liver transplantation, especially for alcohol liver patients transplanted? Do they start drinking after?
No, most of them didn't, because to have the transplant, you have to have 6 months of abstinence from alcohol. So they continued the abstinence.
Okay, they continued.
Yes.
Thanks.
Yes.
I have maybe one comment, because you called type 2 diabetes, and the diagnosis was based, as PTD recommends, based on glycemia. However, in autoimmune liver disease, it's rather common to have type 1, and in alcoholic liver patient, we rather diagnosed, let's say, type 3 of diabetes. So as you will prepare your manuscript for presentation, I recommend to tell rather diabetes, not diabetes type 2, because as I saw in methods, you didn't differ which type it is, and it's rather different by pathology.
Yes, of course. Thank you very much.
Thank you very much. Okay, now I'd like to ask to present the next paper entitled Anamnesis and Risk Factors in Early Diabetic Retinopathy Referral, a retrospective study, and this is the online presenter. Feel free to share your screen with us.
Hello, ladies and gentlemen. I would like to ask if my screen is visible and if you can hear me.
Yes, we can hear, and your screen is visible.
Okay. So, ladies and gentlemen, my name is Filip Kowalik, and I have a delight to present you the results of our work today. We will be talking about diabetes and complications of this disease, with particular emphasis on diabetic retinopathy. As we can see on the left side, the prevalence of diabetes is estimated to be twice as high by the time of 2050 as it is now. Diabetic retinopathy, in turn, belongs to the most common causes of avoidable blindness worldwide. This clinical entity affects even 3 out of 4 patients living with diabetes for 15 years. And there are several established risk factors that correspond with occurrence of retinopathy, with suboptimal glycemic control being a very important one. In our research, we analyzed 75 optical coherence tomography scans and compared the results with anamnesis collected when necessary by means of a phone call. We managed to complete 47 data sets with the results summarized here in the table on the left side. Please note that we questioned the patients about the presence of certain comorbidities. The aim of our study was to see whether there were certain tendencies in our group of patients. Now let me tell a couple of words about the OCT scans. Here we can see a picture of normal macula, of normal retina with macula being thinner in the central part of retina. On this slide, there are 3 pathological findings, and we searched for these findings in every OCT scan. There, macular edema is present in the central part. White tiny dots here below indicate the presence of microaneurysms, and those larger white spots with shadowing beneath them suggest the presence of hard exudates. Based on the presence of those signs, we developed a score, and I will tell something more about this later. Now let me make a short excursion into the progression of macular edema. On top, we can see once again a normal OCT scan. The letter B indicates an initial stage of retinopathy, of macular edema with subretinal fluid collection. And the letter C is showing an advanced stage with prominent cysts and subretinal fluid collection. So now let me tell something about the collected results. For calculations, we used an SPSS program with significance set at 5%. Based on the presence of those 3 signs, we attributed points to the patients. And when one sign was present in one eye, a patient would become 1 point. Thus, with all signs present in both eyes, 6 points could be given to a patient. On the left side, in a table, there are results of the first calculations summarized, and our group of 47 patients could be divided into many different groups based on the presence of certain factors. On the right side, the results of Mann-Whitney tests allowed us to state that there were statistically significant differences between the group of men and women, with men having more frequent ocular signs. To the kidney disease, I will come a little bit later. We checked also our group for the presence of certain correlations, and a significant inverse Pearson correlation was found between the score and patient's age. It means that in our group of patients, the younger patients were having more frequent ocular signs. Subsequently, we divided our population into the group of men and women because those 2 groups were significantly different from one another. And using the same principle and Mann-Whitney test, we established that men with lower limb ulcerations were having more frequent ocular signs. As far as the kidney disease in the group of women is concerned, the results were at first puzzling for us because the women who did not declare kidney disease, they had more frequent ocular signs. It could be attributed to the sample size and to the method of collection of data, but I would like to comment on that. And although that there are certain well-established links between kidney and ocular disease, and there are studies which show a clear correlation between them, a recently published research indicated that there is also a certain discordance between those 2 clinical entities. In this group of patients, around 40% of them were were having one disease but were not having another. Conclusion, those two clinical entities are multifactorial, and there are many factors that play an important role, with genetic and ethnic ones being also important. To conclude, we observed significant differences between groups of patients created based on anamnesis. Thereby, we suggest that men with lower limb ulcerations and also younger patients may particularly benefit from an early referral to ophthalmologist. Findings concerning kidney disease do not necessarily go hand in hand with diabetic retinopathy, and further research in this field is needed. Last but not least, early screening and treatment of diabetic retinopathy is very important. I would like to thank you very much for your attention. Here are my references, and I would be happy to answer your questions.
Okay, thank you very much for your presentation. Can you tell us what was your contribution to this work?
Yes, so together with my colleagues, Mrs. Wolszczak and Mr. Nowakowski, we identified the patients in the clinic register, we completed the database, and also the anamnesis by means of a phone call. I made the statistical analysis and prepared the discussion for today's presentation.
Okay, thank you very much. Now we'll move to the discussion. Are there any questions from the jury?
In patients with diabetes, there is very common to have microangiopathy and complication, both or alone, ocular or kidney or even neuropathy. In your research, neuropathy didn't differ significantly or influence RD. However, did you compare neuropathy by any clinical exam or just by anamnesis?
So thank you for this question. Neuropathy was assessed based on anamnesis.
Well, this is big.
By questioning.
This is big problem in clinical practice, in fact, because it may be underestimated, in fact.
So congratulations on the study. What is your hypothesis about the association between the lower limb ulcerations and ocular angiopathy?
I think that this could be related to the suboptimal glycemic control, which contributes to the ulcerations in lower limbs, and it could be a hallmark of this pathology. And when the glycemic level is not controlled properly, those both diseases can develop.
Yeah, but could you check the levels of glycemia or glycolated hemoglobin or any other markers?
Unfortunately, we couldn't make this quantitative test. We could only make a qualitative analysis with anamnesis and data concerning age and duration of disease.
Thank you. Thanks.
I am nephrologist, and I have one question, because you showed us that diabetic kidney disease, it's not fully related with diabetic retinopathy. I would ask you to tell how many % of patients with diabetic retinopathy had diabetic kidney disease, and how many patients without diabetic nephropathy may have diabetic kidney disease. Could you tell me that numbers?
Does the question concern our group of patients or population studies?
Your group of patients, of course. Yeah.
Mm-hmm. So this is also a I think that could be improved. Our group of patients was not very large. In the subgroup of women, where the statistical difference was significant, it was around a group of women of 22 women. There were 8 women with kidney disease, and the rest without this entity. So 14 and 8 people in subgroups.
Okay, thanks. Thank you. Yeah.
Okay, thank you very much.
Thank you.
Now I'll ask to present the paper entitled Screening of Serum Uric Acid Levels Using Test Stripes, followed by a medical history questionnaire.
Ladies and gentlemen, good morning. My name is Aleksander Urbas, and I'm really glad I have the opportunity to present the results of our study called Screening of Serum Uric Acid Levels Using Test Strips, followed by a medical history questionnaire conducted by Department of Internal Medicine, Autoimmune and Metabolic Diseases of Medical University of Silesia. In the next few minutes, I will try to outline the background of the medical problem related to uric acid, and describe the aim of our study, materials and methods we used to accomplish it, what we found out, and what we can conclude out of this. So the main topic of our study is uric acid, a heterocyclic compound, the derivative of purines, and the main product, the final product of its metabolism. It's a well-known pathogenetic factor of various chronic diseases like gout, chronic kidney disease, urolithiasis, cardiovascular diseases, or metabolic syndrome. Increased uric acid levels, called hyperuricemia, leads to its crystallization, and the most characteristic sign of such a state is painful arthritis with swelling, redness, and warmth, called gout attack. So the drugs are widely used in treatment of hyperuricemia. However, the non-pharmacological actions are crucial here. It is included in reduction of risk factors like the aforementioned chronic diseases like obesity, diabetes, or chronic kidney disease. Very important is also diet, all purine-rich food like meat or seafood, but also fructose-rich food and high alcohol consumption tends to increase uric acid levels. Low physical activity can lead to diabetes or obesity, so it's also a risk factor. It is also important to look at patient medications, especially acetylsalicylic acid or diuretics. Other factors are non-modifiable, and we can mention their age, gender, or genetic factors. And our study is focused on investigating the impact of these various factors I mentioned before. In order to do so, we performed uric acid concentration test using test strips, user blood monitoring system, followed by an original history questionnaire in a group of 195 patients. We excluded from our study patients with current neoplasms and pregnancy patients. In our survey, we asked patients about their anthropometric and demographic data, about their diet, fluid and alcohol intake, aforementioned chronic diseases, also medications, and their physical activity. And our study group consisted of 139 women and 56 men. The mean age was almost 53 years old, and mean BMI was 26.9. And moving on to the results themselves. The mean level of uric acid in our group was 5.6 milligram per deciliter. However, in the male group, this average was significantly higher than in female group, respectively 6.45 milligram per deciliter versus 5.26, and this was significant difference. In terms of anthropometric data, we found a weak correlations between uric acid levels and age, body weight, and height. Person correlation coefficients were respectively 0.14, 0.12, and 0.18. The aforementioned diet had no significant influence on the urate levels, but the nuts were exceptions here. We saw the reduction of urate levels in groups with higher consumption, and these differences, as you can see, were also significant in terms of statistics. Next important factor we checked were chronic diseases. We analyzed several of them, and we found out some differences between groups with and without such diseases like coronary artery disease, heart failure, chronic kidney disease, and these differences were also significant. We also tried to establish if the patients with more comorbidities had higher urate levels, and in order to do so, we divided patients into two groups, one with less than 2 and the other with 2 to 6 conditions, including chronic kidney disease, coronary artery disease, arterial hypertension, heart failure, diabetes type 1 and 2, and gout. And indeed, in the group with higher urate level, high rate of conditions, the urate levels were also higher. Fluid and alcohol consumption in our study did not show any significant influence. As you can see, we divided patients into 5 groups, dependent on their daily fluid intake, and in groups with higher fluid intake, we saw lower urate concentrations. This difference is the best visible in the extreme groups. However, this tendency is not continuous through all of the groups, and it's not significant. You can also see here a plot visualizing the correlation between urate levels and alcohol intake stated in a standard drink per month, and there was no correlation here. We also checked if the time of measurement has some influence, and the patients tested before 2 p.m. had the highest urate levels, and those tested after 5 p.m. had the lowest. However, this was not significant. In terms of conclusion, we can say that the higher concentrations that we saw in male patients, older patients, patients with higher weight, patients with chronic diseases, this all was expected and consistent with data available in the literature. However, the lack of influence of certain factors, especially alcohol and fluid intake or the diet, it's not clear in terms of interpretation, and the most plausible reason for that we didn't show such differences is the tests we used are not adequate to assess modifying effect of such factors, or our study group size was simply insufficient. And thank you for your attention. Now I would like to invite my dear colleagues on the stage and all of you to ask some questions.
Thank you very much for your presentation. Can you tell us what was your contribution to this work?
Yes. So first of all, we've done a research in this topic. Then we constructed the survey I was talking about in the presentation. Then we collected data from the patients. We constructed a database. We helped our tutor in some minor issues in the statistical analysis, and then we prepared our presentation.
Okay, thank you. Now we'll move to the discussion. Are there any questions?
I think that still the role of uric acid in metabolism is underestimated. I wanted to know your opinion, because you found relationship between uric acid levels and cardiovascular diseases. Do you think that it participates in pathogenesis of atherosclerosis, or it's only bystander in these diseases? It is the first question. And the other one, you did not find relationships between alcohol consumption and uric acid. That is something in opposite to knowledge. So how the information on use of alcohol was gathered?
So the first question was about relationship between the cardiovascular diseases and the urate levels. So according to our knowledge, both mechanisms are somehow true, that the high urate levels enhances the atherosclerosis. However, the cardiovascular diseases are also, and with all its risk factors, are also risk factor for hyperuricemia. And the second question was about alcohol. So, sorry, I didn't understood well what you mean.
The history, how the information on use of alcohol was taken from a patient, because it is not enough to ask, do you drink? Yeah?
Okay, so with okay, I didn't understood. We have asked patients about how much they drink certain type of alcohol, and then counted how much it would be in the standard drink per month. However, we based our data on anamnesis, let's say. So,
if I can ask a very interesting study, congratulations. So the question is, you used the point-of-care testing, and point-of-care testing, also from the needle stick, I guess. So the question is, did you try to compare your results with automated uric acid measurements? How well your test performs? Do you have any correlation data between the point-of-care test and the automated test in the lab? Because it may be some problem here, potentially, of course. I'm not suggesting, but I'm just curious.
Yes, we are aware of that, and I think that is one of the reasons why we didn't find some differences we expected to find. However, we did not compare our methods to the laboratory ones.
If I may add one thing, some of our patients were hospitalized in the department in UCK, and some were tested during the event in February of 2023. So we didn't have any follow-up because it was just one strip test for those patients.
Thank you. You have shown a population of adult males which were in general obese, and showing that there was an increased number of coronary artery disease and diabetes. Those patients are of high likelihood of having sleep apnea syndrome, which is strongly correlated with uric acid. Have you asked for the obstructive sleep apnea, or make any, let's say, questionnaire to exclude or include those with a higher likelihood?
We asked about all of the comorbidities in our questionnaire, and none of the patients declared this condition. So our study did not include any patients with that comorbidity.
So we assume that the population was free of the diagnosis of sleep apnea, and for sure there were some people which were not aware that they were sick, right?
Yes.
Thank you.
You mentioned diet in your work. Did you collect data qualitatively or quantitatively? So how you ask about, let's say, nuts, because we found some changes in uric acid with nuts consumption.
We asked about certain kinds of food in our questionnaire and how often patient is eating this kind of food. So, for example, rather than once a month or 3 times a week. And the same thing we did with the food eaten on the day of the test. So that's how we did
just how often?
How often, and the kind of the food we also asked for that.
So you didn't measure how many?
Oh yes, that's a good point.
And as you had so many points, I recommend you also to perform multivariable regression to exclude some confounders, maybe.
Yeah.
Okay, thank you very much. Okay, now I'll ask to present the paper entitled Prediction Model for the Hospitalization Length Based on Basic Features Using Machine Learning.
So, esteemed jury, dear colleagues, my name is Paweł Korzelowski and I would like to take you on a trip to the future. Imagine that on admission you can predict exactly how much time your patient will spend in the hospital, that you can approximately plan the time of the test and procedures, and, for example, receive the proper amount of money from the National Health Fund. Or imagine the mental comfort of the patient's relatives when they know when they can expect their relatives to be discharged. It's like the SOFA score used in the ICU, but simply better. Sounds too good to be true? Here we are. We did it. But we've also got bad news. It doesn't work. But what exactly have we done? So we've collected the data of 350 patients from an internal medicine ward. Here you can see the age distribution of our patients. The collected data included age, gender, blood pressure, complete blood count, creatinine, as well as some medical history like heart failure, hypertension, ischemic heart disease, type 2 diabetes, atrial fibrillation, smoking, and suffering from a disease with an ICD-10 code from groups C, D, E, J, K, and N. To analyze the data and create a prediction model, simple linear regression was first used but did not yield any results. To overcome this issue, we used the XGBoost machine learning algorithm. It is based on gradient boosting decision trees and is a golden standard in modeling nonlinear relationships between tabular data. Two models were then created. The first one, a regression model predicting the exact length of hospitalization, and the second, the classification model, predicting whether the hospitalization would be longer than 5 days. Both models were trained and validated using 10-fold stratified cross-validation. It's a standard procedure used in machine learning that allows us to use the same data set both for training and testing the model. The regression model that was trained to predict the exact period of hospitalization. Here you can see the curve of predicted values plotted on the curve of target values. We've also included some statistical parameters of this model, but at first sight you can see that obviously both curves don't coincide. The predicted values are off target and oscillate very strongly around the average, which may be better visible on the prediction scatter graph. This is an important fact in terms of discussion and the interpretation of this model. The Pearson correlation coefficient equals 0.29, which is very low and assures us that this model is not suitable for real-world implementation. But then we created a second model, a simpler classification model, to check whether we could squeeze something out from the data that we have, as this task should seemingly be easier. That was, however, to our disappointment, not the case. The classification model measured a sensitivity of 0.77, specificity of 0.39, positive predictive value of 0.61, and negative predictive value of 0.59. Thus, it was only marginally better than a dice roll. It's easy to say that the models don't work because the data was insufficient or inappropriate, but if we dig deeper, we can find the reasons for why it doesn't work and how can we improve it in further work. The analyzed features don't influence the results in a meaningful way according to our model. That might be surprising given the bioplausibility of those things. After all, they all represent the function of specific organs, systems in the body, and the actual state of the patient. So one could think that they would have a bigger impact of hospitalization length. Thankfully, we can see how strong the contribution of certain factors is by looking at the gain graph from XGBoost. As we can observe, some confidence indexes cross zero, so they may have no impact on the final outcome, which we know is not true, since atrial fibrillation, ischemic heart disease, or hypertension, for example, are known independently to extend the length of hospitalization. The data sample might also not have enough cold and hot extremes. The target values mainly oscillate around the average, and that was a serious obstacle in training such a model. In hindsight, we can also say that the term on admission may be too broad. The analyzed group includes patients who were admitted for one-day colonoscopy with parameters within normal range, as well as patients in shock with rock bottom features, who may also spend one day in the hospital, but instead ending their stay with passing away. Therefore, we give a kind of mixed signals to our model and encourage it to predict, to give us predictions near the average. Dismissing patients for planned diagnostic procedures by gathering the data strictly from the emergency department is one option to improve it, or a more rigorous approach in the patient selection with better defined patient selection in a model with more analyzed features might yield better results, or thorough characterization of the patients at the outset of the data, including also the outcome of hospitalization like death, transfer to intensive care unit or discharge might give us more valuable information. The only solution to overcome these issues is to gather more patients and to analyze more features, since the XGBoost algorithm is immune to non-significant variables. Our objective is to be able to have enough patients in the database to add at least full arterial blood gases and electrolyte panel to analysis, and to be able to add more specific medical conditions rather than broad ICD code groups. But maybe our Sisyphean struggles in creating such a model and failing to do so is a testament to a sentence that we often find a cliché, yet is exactly why the work of a doctor is so difficult, that medicine is an art and all patients differ. Thank you very much for your attention. I will be glad to ask the questions with my colleague.
Thank you very much for this presentation. Can you tell us what was your contribution to this work?
So the contribution, so the two of us had the idea to develop such a model and researched existing literature on the topic. And the statistical analysis was performed by an IT student from the Polish Academy of Sciences, who has experience in the field, since we ourselves are only amateurs at statistics. Furthermore, the abstract was also prepared by the two of us. And finally, the data collection and data preparation was done by 4 of us from the internal medicine department. And this step took by far the most amount of time, as it took about 25 minutes of data collection per patient. And then the data preparation included removing duplicates and standardizing the records from the anamnesis. And at times we felt that picking tea leaves in Sri Lanka was more effective than this way of data gathering. But we powered through.
Okay, thank you very much. Now I think we can move to the discussion.
First of all, congratulations. This is a great thing to hear that students have their own idea and they convince the tutors to run it through. So I have a question concerning your model, whether you have included the systemic influencers. For example, there are some hospitalizations that you do the same procedure, but if the patient stays for 5 days, not shorter, then they pay you a few times more. I mean the National Health Fund. This should be also introduced, I guess, if it was not. And whether you have assessed the physician-related length of stay. For example, in my department, I know that there are some, let's say, physicians which tend to prolong the patient's stay, if they may, of course, if it's not witnessed, and these other ones are very fast.
Yeah, that's the factor that gives like, fact is probably unmeasurable factor to include in this model, because we ourselves can't assess whether the hospitalization length was like on time and was right, or it was prolonged. But we know that if we gather enough data from the patients, like from emergency department, this factor can be minimized, since XGBoost algorithm is immune to non-significant variables. That means that if one variable doesn't affect or gives us the mistakes in calculating the model, its coefficient is 0 and doesn't influence the outcome.
Thank you very much. Include your tutor more, and then we'll have some systemic data. Thank you.
I have one short comment, because you said that for improve this prediction system we need to have more patients and more features. So I just want to say that I think that first you need to have more patients and then more features. Will you agree with that?
That was actually one of the limitations, because the number of patients limits the amount of features we can analyze. With the amount of patients we have, we can't just throw in 100 features, because then it just wouldn't work. So we just chose the specific ICD groups and the set amount of features accordingly.
Sure thing.
Yeah.
So congratulations, a very interesting study, although I don't believe we will be able to predict this in the next few years, but maybe in some future. We agreed that there are many parameters you couldn't analyze.
Yep.
But out of those you could analyze, the higher variability were code J. Yeah?
Yes.
So the infections. Can you comment on this? If infections were the most unpredictable factor for the hospital stay length?
The factor that has the most influence was the code ICD-J, which probably most hospitalization was pneumonia, which is associated with the extended period of hospitalization. However, I don't know.
So my question is hospital infections. So infections acquired in the hospital, those are the biggest game changer in the hospital stay. So I think it can be analyzed somehow further in your algorithm.
Actually, we could not analyze or did not analyze if the infections here are hospital acquired or if the patient was admitted because of that.
Yeah, that's my point.
And also that was the factor that had the influence, but only in our model. So we just can't extrapolate it to make it an independent factor for the extended period of hospitalization by this paper.
Well, congratulations on your work. Few months ago, artificial intelligence need to also pass internal exam for specialists, and unfortunately, the IA didn't pass, I'm sorry. So maybe this is the same with your work, as we still are human, and we, in fact, compare as an art, as you already said. So maybe this is still need to give more information to machine learning to help us in our work.
Yeah, but we know that it will be only a tool and it will never replace the doctor, but we shouldn't be afraid of machine learning and AI. We just should accept that it is and it will develop, and we should squeeze it out as much as a tool for us.
And for sure, sensitivity will rise.
Yeah.
Thank you very much for your presentation.
Thank you.
Okay, now I will ask to present the last presentation of this session, influence of infections on cerebrospinal fluid cytosis.
Good morning, everyone, dear jury. I would like to present my work, as it has been already said, influence of infections on cerebrospinal fluid cytosis, and I am the member of student scientific group of laboratory medicine in Medical University of Warsaw. And cerebrospinal fluid is an ultrafiltrate of plasma, and its main role is to develop nutrients to the neural tissue and also protect it by being a part of blood-brain barrier that directly connects with both vascular and system and neural tissue. And the protection also involves keeping blood cells from crossing that barrier because they can cause a brain damage. And the aim of my study was to investigate if different types of infection has an effect on cytosis of CSF, which will also tell us whether blood-brain barrier functions correctly or not. And materials and methods, it was a retrospective study consisting of 138 adult patients at the age of 8 plus minus 9 years, and cell count was detected by using flow cytometry method. And the results, as we can see here, we had 78 patients with pleocytosis above 5,000 cells per microliter, and from those patients, 35 of them had cancer or tumor metastates. 11 had viral infections of the CNS. 10 patients, pleocytosis was the result of infections outside the CNS. 5 patients suffered from neurological diseases, and 17 patients, pleocytosis was caused by bacterial infections of the CNS. And we have here the statistics. And the statistical analysis was performed by Mann-Whitney test. And as we can see, bacterial and cancer was statistically meaningful. Bacterial had around 200 cells, cytosis, and cancer around 90. And the conclusions is that the analyzed study showed that bacterial and viral infections lead to a significant increase in pleocytosis in the cerebrospinal fluid, and those infections are mainly bacterial. And thank you. And
thank you very much. Can you tell us what was your contribution to this work?
I was collecting the data and preparing those paper and statistics and almost everything. So yeah.
Okay, thank you. And now we'll move to the discussion. Are there any questions?
I will ask the question. So, of course, your conclusion is quite obvious, so we know it. But another question would be, there were quite a lot of patients with malignancy, CNS malignancy in your group. So, why those lumbar punctures were performed? Was it before the imaging techniques, before the knowledge of the tumor of central nervous system, or was it a part of diagnostics in those patients?
I didn't have this information because I'm the laboratory medicine student, so we get only this information that I showed. I could only had the laboratory results tests.
So maybe your department is analyzing more complex, like morphology of the cells, or maybe they'll try to calculate the numbers of non-cancer cells. So maybe it's part of some other experiments. I would say so. Otherwise, I see no reason to puncture the patients.
Yes. We analyze the cells. Like some people of my department analyzes. The pulmonary from malignancies, and yeah, so that's the main of it.
Okay, thank you very much.
Thank you.
All of the submitted papers have been presented. We congratulate all of the presenting authors and participants of internal medicine session. At this point, I would like to ask the president of the jury, Professor Marek Hartleb, for a few words to sum up the session.
I join to congratulations to all participants. I think that the jury will agree with me that the scientific content of the presentation was excellent, and mode of presentation was also quite good. I know that it is your starting point in your experience with research, and I hope you will follow this path. You will make the career in the research because it is worth to do that. So I wish you audience, larger audience than here witnessing, thousands of people in the audience and difficult questions from the public. So I'm thankful to jury as well, and I wish you many successes in your work. Have a good day and a whole life also.
Thank you, Professor Halper, for these words. Dear jury, we really appreciate your valuable comments, accurate observations, and work on the presentation assessment. We would like to cordially invite you for the decoration and closing ceremony on the SIM 2024 conference, which will be held today in the Theater Rialto at 6 p.m. I would also like to invite you all for the lunch that will start at 12 and will be served at the entrance to this auditorium. On behalf of the Student Scientific Society, I would like to thank you all for participation in this session, and the session is officially finished. Thank you very much.